All right, welcome to the Massachusetts Family Institute's presentation on assisted suicide and the culture of death. I'm Andrew Beckwith, president of Massachusetts Family Institute, and I have with me today two veteran Massachusetts doctors, Dr. Mark Rollo and Dr. Thomas Sullivan. Gentlemen, thank you for joining me.
Welcome.
Dr. Sullivan, if we could start with you, if you could just briefly give us your background as a physician and talk to us about sort of what is assisted suicide. I know you and I and Dr. Rollo are very familiar with the concept and the legislation that's been pending, but if you could kind of explain to our listeners, how it works, how it maybe differs from pulling the plug, so to speak, which one of my family members confused it with initially.
So do you want me to go first, Andrew?
Sure, Dr. Sullivan, thank you.
Okay, so I'm a board certified cardiologist. I saw patients for 44 years, and about 5 years ago, I closed my practice and started working full time for a software company that helps physicians and hospitals take care of their patients. I've was born and raised in Massachusetts. Well, let's say I was raised in Massachusetts and have lived in the state pretty much for all of my 70 plus years, except for my training. And I practice on the North Shore, part of the Salem Hospital and the Partners system. And I have a lot of experience taking care of chronically ill patients, including very elderly patients who were, on the brink of death. I was the director of a long-term care facility for 35 years in the Ipswich area. So I'm familiar with this problem of end-of-life care. And I feel in the last few years, it's the whole discussion has been distorted and brutal, in my opinion. So I'm hoping that that we will be able to oppose the pending legislation, which is euphemistically, I guess, called end-of-life care. But I could expand on that more. But that's just a brief introduction.
I appreciate that, Dr. Sullivan. Thank you. And Dr. Rollo, you and I have spent quite a bit of time fighting this legislation as well. Can you kind of explain for people how this bill would work in the sense that how would it change things for doctors and the end-of-life care they provide now?
Well, by way of introduction, I'm in primary care. I practice in Massachusetts for a couple of decades, since about 1994. Before that, I was an Air Force physician. So many of my patients are elderly. And this is a fundamental change in the way we practice medicine. Most of us, maybe not so much anymore, but I'm sure Dr. Sullivan, as well as myself, took the Hippocratic Oath going back 2,500 years. And the Hippocratic Oath specifically says, I will not give a drug to a patient to kill himself, nor will I suggest such. Well, this pending legislation is not only suggesting such a thing, it is making it legal, and in some cases mandating that physicians go along with it, whether we like it or not. So it is a corruption of medical practice. It's now legal in about 9 states throughout the country, but more importantly, it has been rejected by many more states. So this has been on the ballot year after year since at least around 2012, when it was on the ballot, and we defeated it. Nevertheless, the Massachusetts, even though Massachusetts voters defeated it.
Dr. Rollo, I want to just, sorry to interrupt you for a second, but I want to just take you back to where things are nationally, and it's a good way to put things in context.
Yeah.
I'll put a map up on the screen now that shows where assisted suicide is currently legal. As you know, the whole West Coast, as well as parts of New England and New Jersey. You've got Montana out there, and Hawaii, And going back to, I think probably when you and I first met in 2012, when we were fighting the assisted suicide referendum. That was a narrow victory. I think 51 to 49%. But I remember that the proponents who were pushing that were talking about how they wanted to establish a beachhead in New England.
Mm-hmm.
And they failed to do that with Massachusetts, but then they established one, I think it was in Vermont the next year. And then if you, looking at the results of that, I can bring that up here as well. There is a state map that shows where people voted for it or against it. I think I can send that to the screen. Interestingly, if you look at this map, a lot of the people who voted strongly against it are in some of our less well-off communities, and those in more well-off communities, kind of the just outside of Boston, and up on the North Shore, Dr. Sullivan, where you are and where I am, people voted for it. So interestingly, people that have less financial means as a whole voted against it. And I think that sort of ties into some of the very legitimate concerns that people have that if assisted suicide is legalized, then those who have less resources will become victims of it, essentially. Is that one of the concerns that either of you gentlemen have?
Yes, certainly. In fact, if you look at that map, I'm right in the middle. I'm from Fitchburg, which is in central Massachusetts, and you can see most of central Massachusetts are blue-collar, less financially well-off, as opposed to, as you mentioned, the North Shore, the Boston area, and some of the western college town areas. And, you know, our legislature is supposed to promote the general welfare. And they should be concerned about everybody in the state. But the state is very divided. And if they were to make this legal, they would be basically pitting different parts of the state against each other.
Right, and we've actually seen situations in other parts of the country where you have individuals who are facing maybe a terminal cancer diagnosis, and they're trying to get treatments, and they're told by their insurance companies that the expensive treatment won't be covered, but assisted suicide pills, which are typically, as I understand it, 100 pills of secobarbital, are in fact covered instead of the treatment.
That's exactly right, and they are coming up with different cocktails for people to try to kill themselves. But it's true. That's whatever cocktail you come up with, it is very cheap in comparison to expensive treatments, like, for example, Barbara Wagner in Oregon who had terminal lung cancer, and Medicaid refused to pay for the chemotherapy, but they sent her a letter, if you can believe it, saying that they would cover her suicide pills. And that's not just an isolated example. It's not just government. It's not just Medicaid that has done that. Insurance companies have done the same thing. And I think we have an example of one that you'll talk about later, Stephanie Packard. But that is a very real concern, that the less well-off people will be steered towards suicide.
Let me
Thanks, Doc.
let me just make one little comment. These assisted suicide concoctions are no longer using Seconal because it's become too expensive. There are newer ones that are not quite as deadly, but they're a lot less expensive, and it just shows how the cost of the better care, palliative care and hospice care, is so much more expensive that even the expensive suicide pills or concoctions are being promoted. But anyway, most places who have these suicide pills are no longer using secobarbital because it's It was even outlawed in some of the execution states where, you know, prisoners would be killed with that. But so things have changed quite a bit. It's all just terrible that we're looking for better and cheaper ways to let people kill themselves and ask physicians to do it. I mean, I could go on and on about this, but
well, I didn't realize that, Doctor, and that's it is frightening. What is being touted now as I guess the more efficient or economical means to end someone's life, if even pills is too expensive?
Well, unfortunately, the most efficient one is to give a direct IV injection. You know, that's, if you remember, years ago, Dr. Kevorkian was put in prison. Now, remember, he was a pathologist. He never saw a live patient, but he developed this IV, which would kill you pretty quickly. And of course, that has been outlawed, but that's the most efficient way. I hate to talk about it in these terrible terms, but that's the most efficient way to have someone, you know, commit suicide or kill themselves. But they obviously have to have the help of a pharmacist or a physician to prepare that, stick in the IV. The current oral medicines it's usually a difference between what's called DDMP and DDMA, which are concoctions of drugs that, you know, typically kill a person within 20 minutes to an hour or two, but there are sometimes agonizing problems, and it's again, I could go on about this, but it's a terrible way to die. It's a terrible way to die. What we really need is more hospice and palliative and compassionate care, and that's what the Medical Society voted for, despite dropping its opposition recently.
Right, and I want to touch on that specifically in a moment, Doctor. But I think it's important to talk through the specifics of what this legislation, specifically in Massachusetts, would do. We're talking about currently House Bill 1926 and Senate Bill 1208, both entitled an act relative to end-of-life care. It's been termed death with dignity in the past. One of the groups pushing is compassion and choices. So they keep coming up with different euphemisms to label the stuff that you're talking about, which is really disturbing. But specifically in Massachusetts,
I was going to say, you're absolutely right. You know, the bills that have failed in the legislature here, they had different names. You know, death with dignity, then they dropped the word death, and they said medical aid in dying, and then that was defeated, and then they changed from medical aid in dying to end of life care. All of those trying to soften the reality where it's basically suicide. And one of the terrible things is you're not allowed to say that on the death certificate, that this was suicide. You have to say it was from some other cause.
Right, and as an attorney, that's one of the parts that I really try to hammer home with people, that you know, look, even if you agree with assisted suicide on a moral basis, some of the practical elements of this proposed legislation are really pretty frightening. That you would have a death certificate for a loved one, you know, let's say it's an aged aunt or a grandmother, and you know, you're not in regular communication with them. You hear that they're struggling with maybe a cancer diagnosis, and the next thing you know, they've passed away, and maybe you know what the details are. If you go and pull the death certificate, it's not going to say assisted suicide. You know, if some other acquaintance or family member kind of encouraged them to take that route, you would never know. So one of the concerns about this bill is that it really is a recipe for elder abuse, and the legislation actually forces doctor to cover the tracks of people who could be encouraging vulnerable older people to end their lives.
It's essentially a legalized fraud to put on the death certificate what the underlying illness is, and not assisted suicide. And you mentioned the elder abuse. it's estimated that in Massachusetts, about 10% of our elderly are subject to elder abuse. And this is, as you mentioned, a recipe for exploiting that. There are stories out there, again in Oregon, where the person who's, I think her name is Kate Cheney, and she had borderline dementia. She essentially doctor shopped. She went to the primary care doctor, who said no, she doesn't qualify. Took her to a psychiatrist. The psychiatrist said no, she doesn't qualify, and he noted that the daughter seemed to be coercive. And then finally, this Kate Cheney was taken to an HMO, so-called ethicist, who said, "Oh yeah, she's a perfect candidate." And within this elderly, demented person was given a lethal dose of Seconal at that time. And so that was an example about how elder abuse can easily take place.
Well, Doctor, there are some safeguards, supposed safeguards, written into the legislation that I think is different from past versions. The current bill before the Massachusetts legislature would require an attending physician and a consulting physician to both agree to the assisted suicide, as well as a mental health consult for the individual who is seeking to take their life. Does that alleviate any of the concerns that either of you have, the need for two doctors and a psychiatrist or psychologist?
No, not at all.
And I would agree with Dr. Rollo. Not at all. There's lots of loopholes, but go ahead, Mark.
One loophole. Back in 2012, I was contacted by a physician, Dr. Bentz in Oregon, who told a story about how he had a patient as a primary care physician who was just given a diagnosis of melanoma, metastatic melanoma. And this primary care physician, Dr. Bentz, referred his patient to an oncologist, cancer doctor. And the cancer doctor called Dr. Bentz back after he saw the patient and said, "Well, I think this person is a good candidate for physician-assisted suicide." And he wanted Dr. Bentz to be the second opinion. Well, Dr. Bentz said, "I've known this patient for a long time. He's depressed about his diagnosis. He's not really a good candidate for assisted suicide. I referred him to you to treat him, not to kill him." Well, that didn't stop this oncologist, who got a colleague, again, a second opinion. He got a colleague who agreed with him. And within weeks, this patient of Dr. Bentz was dead. So it's very easy to find somebody who agrees with you. And as for the depression, it is required, and it's not even mandated, it's suggested that a consultation, a psychiatric consultation be obtained. But the consultant doesn't need to diagnose and treat the depression. What he's required to do by law is to make sure that the person's judgment is okay. So the psychiatric consultation could say, yes, he is depressed, but he does understand the ramifications of his decision to want to kill himself, and therefore it is okay for him to go ahead. Well, that just flies in the face of all common sense, because depression itself can cloud someone's judgment. So those supposed safeguards are not safeguards at all.
And Dr. Sullivan, you have anything to add to that?
Well, there's no enforcement mechanism, so if there's abuse in this area, as far as I know, the letter of the law, letter of the bill that's being proposed doesn't hold anybody accountable for not following the law and getting the proper consultations.
That's right, and that's still not the case in Oregon. There are people, pro-assisted suicide people often tout Oregon. They say that there hasn't been any evidence of abuse. Well, first of all, there are evidence of abuse, and I've just mentioned but there's no, as Dr. Sullivan said, there's no reporting mechanism. There's no enforcement. So that is really an empty argument.
And the thing that even makes it worse is what we just talked about. The way the state and the Vital Statistics Department, the way they collect information on morbidity and mortality is they look at death certificates. And if you're basically lying on the death certificate for the cause of death, and you're not allowed to write suicide in there as well as underlying also other causes, how can the state even look at the statistics of morbidity and mortality and come up with a reasonable conclusion? It's a distortion of the facts.
Right. Yeah. And they even say that public records will not be kept on assisted suicide. So not only do you lie on the birth certificate, on the death certificate.
So remember, the reason this was written into the law is the advocates for assisted suicide convinced a certain number of legislators to basically lie and cover their tracks by not allowing suicide as a cause of death, covering their tracks.
Well, I remember those complaints when we had these legislative debates from other jurisdictions that had already passed it, that it was very hard to get any type of accurate or detailed data on how often this was happening, how many people it was affecting. So the proposal here in Massachusetts is to allow assisted suicide for quote unquote qualified patients. And the way the bill works, to be a qualified patient, you've got to be an adult, so it would apply to people over 18, although in Europe, we're seeing a push now for this to be allowed for children. So the classic slippery slope argument is definitely real. And it has to be a terminal disease, so it can't just be used for, say, depression or something like that. Although again, in Europe, which tends to be a decade or more sort of ahead of the rest of the world on this issue, you also have instances of people requesting assisted suicide because of sort of a lack of a will to continue living. So not a terminal disease, but some type of depression. And then really the trigger that they hang their hat on is that you have to have 6 months or less to live. But that's a diagnosis that, can be off considerably. I remember one of the first legislative hearings I went to on this issue, there was a man who testified to the panel at the State House and said, look, I was diagnosed with 6 months or less to live 27 years ago. And that really struck home with me because, he could have been someone who, cut his life, I think, in half almost at that point, if he'd been allowed to. And I've heard fairly consistently that end-of-life projections or diagnoses have an error rate of about 30%.
I'll give you one famous example. Stephen Hawking, the famous physicist,
right,
who was diagnosed with Lou Gehrig's disease in his 20s, and he was told he only had perhaps a couple of years to live at that time. Well, he just recently died about 50 years after his original diagnosis. So the idea that doctors can reliably give 6 months to live to some patients is absolutely erroneous, much if not most of the time.
Again, I would agree with that. Every doctor who takes care of really sick patients knows how difficult it is to pinpoint that. There are many, many times when, in fact, one of the criteria to get into hospice, which is paid for by Medicare and some other plans, is that you have to make a diagnosis of less than 6 months to live. But I've seen plenty of cases where, and I know of one that was not my patient, where the person was admitted to hospice, but he kept getting readmitted every 6 months, and then he lived for another 5 years.
Wow.
Yeah, that's a common experience. If somebody goes on hospice, And then the 6 months go by and they're taken off of hospice. So that's just evidence.
Well, speaking of that, gentlemen, I think you may both be familiar with Dr. Roger Cleaver, who is a fellow physician here in Massachusetts. Can either of you kind of walk us through his situation briefly as to why he's part of this assisted suicide story?
I've actually debated Roger. He knows me well. I know him. We've debated in front of the Massachusetts Medical Society and also the American Medical Association on opposite sides of this. Roger has a tough case. He's got metastatic prostate carcinoma, and I can see his dilemma. You can certainly sympathize with his issue, but I think the solution is absolutely the wrong one. He's an internist, and the American College of Physicians, which represents most internists in the country, they are absolutely opposed to a physician-assisted suicide. But Roger makes a good case, and it's just that you have to discuss this, be realistic, and again, offer more hospice and palliative care and compassionate care. And that's something that, Roger and his colleagues just don't emphasize that.
So as an attorney, I found his situation interesting because he's trying to get the law changed in Massachusetts through a lawsuit rather than through the legislature. And I'm reading that he files this lawsuit because he's got, I think, stage 4 prostate cancer. And during the course of his lawsuit, while the case is pending, as I show on the slide here, he actually gets a better rediagnosis. His cancer was in remission. And so he kind of fits that mold of people we were talking about, where they get an end-of-life diagnosis, and then that turns out to be not true, for which we can rejoice for several reasons, for him personally, and also for what it probably did to his lawsuit. Now, there was just a ruling in January, a couple months ago, where a Massachusetts court denied his request to change the laws on assisted suicide. So that's good. That was a win for life and for upholding our current laws. However, they did say that doctors must be allowed to, I'm going to try and quote it here, the attending physician may, get the right language here, may provide information and advice on medical aid in dying to terminally ill, competent adults. So may provide information and advice, but can't actually prescribe the medication or the poison. So what are your thoughts about that? That's a change, apparently, to the status quo, that doctors may now give advice and information.
Well, I think the important thing is that they said that there is no right to assisted suicide in Massachusetts. As to saying what a doctor may or may not say in an exam room is kind of moot from my point of view. It's hard to legislate what actually is discussed, and it kind of doesn't matter what is discussed if there remains a prohibition against following through with assisted suicide. So the most important part of that decision was that saying no, people do not have a right to have a physician give them a suicide cocktail.
Yeah, that was an important decision, and of course he's appealing it. So we'll see where that goes. It was the lowest sort of trial court level in Massachusetts, and he's going to try to appeal it up through the state court system, and so we'll be monitoring that. But Dr. Sullivan, perhaps you could talk to us about the Massachusetts Medical Society. They've sort of changed the position on this issue within the past couple of years. They were opposed, and now they've taken a neutral stance. And I know you had some thoughts on that, being a past president, if I understand correctly, of the Mass Medical Society yourself.
That's right. I am a past president of the Medical Society. Its Medical Society has 25,000 members. We're the oldest in the United States. 239 years old, a long tradition of ethics. And it's the position of the medical society is confusing to some, and unfortunately, the way the media presented it was that we were in favor of assisted suicide, which is absolutely wrong. We had long debates over a couple of years, and at the time we did our actual vote to drop opposition, which I was terribly opposed to, the name of the bill in the legislature was medical aid in dying. And so I told our House of Delegates, I've been practicing medical aid in dying for 40 years at that time. I always help people ease their suffering and pain, but I never gave anybody a prescription to kill themselves. So again, we took the position in the medical society that it's really compassionate care and hospice care and palliative care that are required. And in fact, I brought it to a vote. I said, let's decide on what medical aid in dying means. And so we included those three options, and we specifically voted against physician-assisted suicide as one of the roles for medical aid in dying. Now, after the vote came to continue our opposition or to go neutral, the vote was to go neutral. It wasn't by very much, but some people forget that what we call medical aid in dying specifically excluded physician-assisted suicide. We did say if the law passes, we'll have to include that as a legal option, but the sentiment of the medical society and all of my colleagues who were past presidents, at least at that vote, all were on our side of opposing physician-assisted suicide. So we've been engaged in this for a number of years, looking for the most humane way to help treat, end-of-life patients.
It's also
Thank you for
pointing out that it was just 6 years ago, or now I guess it's close to 8 years ago, in the 2012 referendum. At that time, Mass Medical Society was strongly opposed. It was something like 75% to 25% opposed to assisted suicide. And that has eroded until recently. But as Dr. Sullivan mentioned, the American Medical Society, the national organization, is still strongly opposed to suicide, as is the College of Physicians.
Yes, and just to adding what Dr. Rallo just said, I was at that debate at the American Medical Association, the head of the ethics committee of the AMA that was advocating for continuing its opposition. He's actually an academic psychiatrist from Boston. I mentioned that in my testimony to the State House, and spoke to him personally and asked if I could use his name, Dr. Sabin. And he said absolutely yes, that he was opposed to the bill in Massachusetts. So not only the American Medical Association and the American College of Physicians, but also the World Medical Association. And I spoke to the leader there of the World Medical Association when we were at the AMA debate, and they're still opposed to this. Most medical societies and associations around the world are opposed to this. It's only a few who become neutral. Even in the state of Washington, where the bill was passed a number of years ago, the Washington State Medical Society is opposed to it, and the legislature passed it over their opposition. So it's a big issue.
Yes, you both signed, and I think probably helped draft a letter recently by over 100 Massachusetts doctors stating their opposition to assisted suicide, and publicized that. I think that was wonderful. Have you gotten any feedback from legislators or from the Mass Medical Society on that letter? Again, with over 100 doctors signing their name to it.
I have not me.
But speaking of that, I think, and maybe Dr. Sullivan knows the numbers better than I do, but this whole change in the position of the Mass Medical Society came on the heels of a questionnaire that went out to members of the Mass Medical Society, and there was only about a 12% response rate. Is that what you remember, Dr. Sullivan?
Yes. In fact, the exact the results were 36.1% were opposed to changing our positions. 36.1% were in favor of it, and then the rest were neutral. And so, unfortunately, even though it was equal, opposed to in favor, the fact that the rest were neutral ended up guiding the final decision. But you're right, only 12% of the registered physicians and members of the medical society got a chance to vote on this.
So roughly 87–88% of the members didn't say anything one way or the other.
That's right.
So this was kind of, and as I mentioned, it was just 8 years ago or so where the vast majority of physicians were opposed to it. So this was kind of manipulated in the sense that they put out this questionnaire and then they ran with that, with the result of the questionnaire, despite the fact that only about 12% respond.
That's right, and I'll tell you, my feeling behind why the sentiment among physicians has changed is that we have so many specialists in Massachusetts. You know, we have more doctors per capita than any other state in the country, and a huge number of them are specialists who don't have any familiarity with taking care of dying patients or people at the end of life. And so those specialists, you know, basically don't feel comfortable or competent in this kind of situation. And so I think that's why, you know, physicians tend to want to give to their patients what the patients want. You know, there are obviously some major exceptions to that, but they tend to, you know, it's to give them what they want, if it's, as long as it's legal and safe and that sort of thing. But so many of them, again, have no familiarity. It's a difficult situation. This is not a simple issue. So I believe that that's why the votes have started becoming more neutral rather than in favor of physician-assisted suicide or opposed to it. I think it's just a lack of familiarity, because it's not an easy thing to take care of people who have terminal illnesses and you know they're going to die.
Understood. And talking about complicated issues, gentlemen, I want to kind of switch tracks a little bit now to something that's very current in all of our minds right now with the coronavirus, the pandemic worldwide, and how that's affecting healthcare in general. I just want to read you a couple quotes that have been in the media recently. There's an article in The Atlantic about the situation in Italy and some of the tough choices that doctors there are facing, and they've been receiving guidance that says, for example, quote, "It may become necessary to establish an age limit for access to intensive care. Those who are too old to have a high likelihood of recovery or who have too low a number of, quote, life years left, even if they should survive, would be left to die. These criteria apply to all patients in intensive care, not just those infected with COVID-19. And so that you have that in Italy. Then you have apparently out of Alabama, this is from the New York Times, saying that people with severe or profound mental retardation, as well as moderate to severe dementia, should be considered, quote, unlikely candidates for ventilator support during a period of rationing, which there are concerns we may be facing with the ventilators and the coronavirus. And just, I think it was today, perhaps yesterday, the Federal Office of Civil Rights came out with guidance to sort of address these concerns. And they said that persons with disabilities should not be denied medical care on the basis of stereotypes, assessments of quality of life, or judgments about a person's relative worth based on the presence or absence of disabilities, and that our civil rights laws must protect the equal dignity of every human life from ruthless utilitarianism. And I know for me, when I look at the situations sort of that we're being thrust into, the doctors and nurses are being thrust into because of the coronavirus, that idea of a ruthless utilitarianism, where individuals who have a quality of life that falls below some arbitrary threshold are no longer worthy of care or legal protection. And that is the exact concern that I have with the assisted suicide, is that it says if you're diagnosed with certain level of disease or terminal situation, If your quality of life is not high enough, then it's no longer worth protecting. And that's the mentality inherent in so many of the arguments for assisted suicide that we've heard at the State House and elsewhere. People talking about wanting to maintain their own autonomy and dignity, and that their life at some point no longer becomes worth living. And if it's not worth living because the quality is too low, then they want the legal protections removed for that. But obviously the concern is, that's a moral concern of itself for the individual, but for society as a whole, once we cross that line, the more pressures, whether they're financial or in this case, I guess, resource or logistical, put on our healthcare system, the more we're going to have a bent towards that, as the New York Times says, ruthless utilitarianism. Actually, that's from the Office of Civil Rights. So what are your thoughts on how rationing and making those tough decisions and doing it wrongly, perhaps in some instances, could affect the assisted suicide?
Well, in that context, you could say that the fear is that the right to die can become a duty to die. And you can imagine in the legal, if the situation, say in Massachusetts, where that assisted suicide were legal, that would put pressure on people who were on ventilators, about to be put on ventilators for coronavirus. It would give them that subtle societal pressure of, well, why don't you just get out of the way? Why don't you just opt for suicide and let this younger, so-called more productive person be given the ventilator? So it just shows you that state-sanctioned suicide is going to put subtle pressure or not so subtle pressure on people who opt for suicide. So it's very dangerous in that respect too. The so-called right to die can morph into a duty to die for some people.
That's right, the duty to die.
Let me add to that. First of all, this is not a new problem. The pandemic is not the first time this issue of triage and selection of patients live or die. When I was a medical student more than 50 years ago, I worked in a dialysis research area where kidney dialysis was brand new. And there were these shortly after that, when dialysis became a lot easier to do and less expensive, there were basically these life and death committees in hospitals that had just a single or two or three dialysis machines. So, and then look back hundreds of years, people have always been faced with this dilemma. Look at the Crimean War, where Florence Nightingale made her name for taking care of all these sick and dying patients. And that was compassionate care. You made each individual feel helped. And that's the problem. I agree with the Office of Civil Rights. We shouldn't categorize people and put them in these broad categories. Every person has to be considered as an individual. And you can ethically, a person who's in terrible pain and suffering, sedate them to the point of unconsciousness. That's considered ethical by the American Medical Association, by the American College of Physicians. You want to relieve their pain and suffering. But in times like this, where you don't have enough ventilators, you have to evaluate each individual case. I read a story in Italy of an elderly priest who gave up his ventilator for a young child, and the priest died.
Wow.
And the point is that you make triage decisions based on need and based on how severely ill a person is, not on how much money they have or how old they are or what their cognitive ability is. And these are the kind of things that are being discussed now. This utilitarian ethic that if you're useful, we'll take care of you. If you're not useful, then you go, lower on the list of priorities. That's the kind of thing that needs to be avoided. Any kind of triaging has to be on the basis of a need of that particular individual, and not saying one individual is any more valuable than another.
Right. And I was glad to see the Office of Civil Rights sort of put that advice and guidance out there and to do it fairly early on in the process. And hopefully it doesn't get to that point. I guess we'll know more as the weeks progress. And part of the result of this global crisis is the legislature is occupied with other things, and so a lot of the bills are just being put on the back burner, including this one. As far as I understand, it's been extended procedurally until April 1st, which is not that far away, just a couple of days now. So it'll probably get extended again, I would imagine, and butt up against that July 31st deadline when this session ends. So we'll keep everybody posted on that. I'm sure you'll be tracking it as well. I really appreciate your time today. Any sort of save rounds or final thoughts on this issue before we wrap up the presentation?
My final thoughts are treat everybody as an individual. Don't put them in classes where you exclude certain classes, whether they're disabled or whatever. Treat everybody as an individual, evaluate them, and advocate for the legislature to provide more funds for compassionate care and palliative care and hospice care, the way the Medical Society wanted it.
Good, Dr. Rollo.
Just don't corrupt the medical profession. Don't turn a healing profession into a killing profession, number one. Number two, don't create incentives to steer the poor, the vulnerable, the minorities, the people with disabilities. Don't steer them towards suicide to benefit the affluent, who tend to be the ones who are more pushing for physician-assisted suicide.
That's right, as we see from the voting map from 2012. All right, thank you both, gentlemen. Appreciate your time.
You're welcome.
Thank you for the work you do, tending to our families and their health. And like I said, we'll keep you posted on this legislation. God bless.
Thank you.